So I'm Teresa Sobieschuk. Some of you met me last week and others of you didn't, but I'm the coordinating professor for this course this term. It's our first International Development Studies course here on campus because before this term we didn't even have a rubric. So we're so excited that we threw together this lecture series, and it's going to be a series of listening and talking to development practitioners, international development practitioners, some from on campus, but mainly from town or from even as far away as Hamilton or the Bitterroot, who will be talking a little bit about some of their real life experiences related to various aspects of international development. So it could be on a very grassroots level, like I talked about last week, the Pohn-Harry Lee Foundation, could be, broader thinking types of lectures. And so we're just delighted that we have members of the community here with us, but also members of the community like Dr. Nancy Fitch sharing their time with us to share their expertise and so that we can learn from them. So just a little bio on Dr. Fitch. She is actually a doctor, not a PhD. So she's an MD from Duke University in 1980. And then she did a family medicine specialization at the University of Minnesota in 1983, or completing it in 1983. And it's actually even before my time, she was the director of Curry Health Center here on campus from 1985 to 2001. She has lived and worked internationally all over the place, including Armenia, Rwanda, and Mozambique from 2001 to 2011. At this point, she's based in Montana, but she's traveling and consulting a lot to various places, again, to parts of Africa, Haiti, and Pakistan, and she is able to help them with international public health issues. Her areas of specialization are several, including HIV/AIDS, primary health care, public health, health financing, and quality of care. So with no further ado, I'm going to turn it over to Nancy.
Okay, so we're a small group, so I really hope we can discuss things. And I sort of did this to ask some of the questions that I don't know the answers to. So this is sort of just what was on Nancy's brain as I was putting together a presentation. And I'm sorry, we have to introduce ourselves, so if you don't mind.
Sorry for it.
I'm
Kisco
Okay.
from Japan.
Okay. What year in school are you? What year?
Junior.
Okay, great. And your major?
My major is environment and development.
Perfect. All right. Okay, so I'm going to try and throw out some hard questions that I still don't know the answers to. But I won't necessarily give you any answers because there aren't easy answers to some of these. But one of the ones I put up here was, are we trying to save lives today or are we trying to save lives tomorrow? And that sort of, I'll explain how that becomes a question because that's an awful choice, right? And I'll give you some examples of how it is an awful choice that we deal with sometimes. And I'm just going to this is the agenda. Basically, I have some introduction stuff. Then, we hear these awful things about refugee crises and how bad the rest of the world is. And so I think there's a question of, are we making any progress? Is the world getting better or worse? Are we trying to help poor parts of the world and are they getting better? So I'm going to share some of that. And then I hope not to get academic. If this gets academic, we're going to skip it. But basically, the world has, or the UN, which is probably the UN, there's some agencies in charge of global health, used to have changed their sort of framework on how they do international development from what was called the MDGs, or the Millennium Development Goal, to sustainable development. And sustainability is a huge theme in everything these days. So we're going to talk about sustainable development. And I'm going to talk about emergency relief or development, and what's the difference between the two. One of them is saving lives today, and one of them is saving lives tomorrow in a very simplified version. And so what's priority? How do you choose? And then I'm going to talk about 3 big programs in the world that I think are remarkable and noteworthy, and one of which, the HIV one, I spent 10 years working on, so I'll talk more about that one. And then then just some general stuff. So if it gets boring or if I see anyone nodding, I'm going to start all over and just sort of say, what am I not talking about? What doesn't make any sense? So this is just me. I worked at Curry Health Center for 15 years, and that actually was pretty good preparation for international work, because my job there was actually, I was the big cheese. I was in charge of hiring people and budgets and stuff like that. And it turns out those skills are actually very useful everywhere. And they're actually the kind of skills that are mainly missing in some of the developed part of the world. They don't know how to do a budget. They don't have experience running organizations. So anyway, but then some of the places I worked in Armenia. Who knows where Armenia is? Tell me what countries it borders approximately.
Well, it's in Eastern Europe. Is it over, what would be, is it by Turkey?
It's east of Turkey,
Maybe that's the only one I know.
north of Iran, south of Chechnya, great location here, and then next to the Caspian Sea, kind of near Azerbaijan, that area. So, and it's got 25,000-foot mountains. It's near Sochi, where the Russian Olympics were. It's a very interesting part of the world. Anyway, then I worked in Africa in some of the hardest hit countries in the HIV program, and spent 8 years trying to help them deal with the HIV epidemic, and now I work when I feel like it, which is really fun. Okay, so are we winning or losing in international development? So just in case you don't know, the red is where all the disease is. So you can tell there are healthy parts of the world, and then there are parts of the world, particularly sub-Saharan Africa and Afghanistan, and usually Haiti is colored, but it's so tiny you can't see it. Those are that's where most of the disease in the world is, and it's you know, life expectancy is low. Here you can get an example of, you know, life expectancy at birth in sub-Saharan Africa is 51 as opposed to 78 in high-income countries. Infant mortality is really high in sub-Saharan Africa, 92, whereas in our country, 6 per 1,000 live births, and children die really 5 times more often in these poor countries. So they have serious health problems. Now there's something called an epidemiologic transition. What that means is that as countries develop, they go through a sequence of development. So like this is true of Europe and the United States. It's also true of all the countries in the world. There tends to be a progress that countries go through. They go through it often in different paces, but the sequence is the same. And I just want you to know what the sequence is. Here's like the least developed countries here, where people die all the time. They have very high death rates, and their birth rate is about the same as the death rate, and so the population stays low. And then they start getting clean water and better nutrition, and their death rate starts to fall. Their birth rate remains high, but because their death rate is falling, their population starts to boom, okay? And then the third one, which is probably where Africa is right now, the death rate is falling. The birth rate actually starts to fall, but the population is still booming, okay? And then here are probably where we are, where the developed countries are now. And what you notice is that the total population starts to stabilize. I tell you this because this is hope for the world, right? If the countries with the really high birth rates, if they get their income and their development reaches a certain level, there's hope. If they do, and it's likely that they'll do what other countries have done, then they quit having so many babies because their babies aren't dying. Okay, and their population starts to stabilize, and even in some countries, their population starts to decrease. And as we face, you know, our planet getting so crowded and running out of resources, it's, you know, oftentimes I hear people say, oh, well, just let the poor people die off because we're too crowded anyway. But really, given the history of the world to date, if they reach a certain income level where their children are likely to survive, they stop reproducing. Their use of family planning goes way up. And Africa is well on the road there. So, and this is not spermatozoa all over the screen. This is actually a very interesting slide. I'll try and explain it. For all over the world and in low-income, middle, high-income countries, death rates in the last 40 years have dropped dramatically. So whether people are dying in childhood or in childbirth or old age, the death rate for every population age group has fallen dramatically. So the world, people are dying a whole lot less than they were 40 years ago. There's one blip right there, that red one. That's the HIV epidemic in Africa. That really turned the tables on life expectancy for some time. But every other age group is living longer. So there's been, I'm trying to convince you that there really has been a dramatic improvement in health in the whole world in the last 40 years, which is pretty amazing. Okay, so I'm comparing here Sweden and China, their mortality rates. And you can see that Sweden, which is probably one of the healthiest countries in the world, is about 100 years ahead of China in terms of improving their death rate. But China's catching up, and so are the other countries. And they call this, we're going to talk about the grand convergence, where it looks like the health of even low-income countries is dramatically improving and approaching that of more developed countries. So what I'm going to do is there were 8 Millennial Development Goals, very big ones, like eradicate poverty and hunger. So those are really high-level goals. These MDGs, Millennium Development Goals, were written, I think it started in 1990, 95, and they were to last 20 years, and so they ended just last year in 2015. And
By the UN?
written by the UN, yes. With 180 some, I think 191 countries signed on to commit to this. So basically the whole world signed on to these goals. And it's guided a whole lot of, most of international development falls into these 8 goals. So I'm just going to briefly go through them, but if you look at in the top left, 1990 versus 2015, in 1990, 47% of people in developing countries were classified as extremely poor, living on less than $1.25 a day. And in 2015, it was 14%. So that's a huge improvement. And that's not just percent, it's actually the absolute number of people living in extreme poverty have decreased dramatically, down from 2 billion to 800 million. So even though we think that there's still way too many poor people, that's huge improvement. We don't always know that. We think the world is falling apart, but okay. Achieve universal primary education. We want every child in the world to finish 6th grade. And again, there's been a huge improvement. In 2000, there were 100 million children out of school. In 2015, that's cut by half. And again, the enrollment rate has gone up dramatically in 20 years. So that's huge, if people are learning how to read. Okay. Promote gender equality and empower women. That's huge as well. And again, there's been enormous improvement, still a long way to go. But if you look at primary school enrollment in Southern Asia, it's gone from 74 girls for every 100 boys to 103 girls per every 100 boys.
Wait, how could that be? It's over 100.
Statistics, yes.
The older ones going back to get schooling.
I don't know the details. Okay. Yeah. But anyway, I mean, there's still a long way to go, and there's certainly parts of the world where it's getting worse. But overall, there's been a huge improvement in gender equality as measured by access to education.
And what is LAC?
Latin America and Caribbean. So there it's getting worse at the moment. Women still earn 24% less than men globally. Now, I didn't look into these, exactly what they mean by all the data, but it's usually pretty robust. Anyway. Okay, now we come to some health ones. Reducing child mortality, and again, the global number of deaths of children under 5 have dramatically decreased. And why is it? We're going to talk a little bit about why, but certain health interventions, for example, here they talk about measles vaccine, are now much more widely available than they were 20-some years ago. Water is cleaner, medical care is more available, more women have access to skilled birth attendants when they give birth. We'll talk about some of the specifics, but overall, I mean, it's huge. And improved maternal mortality. Many more women are actually, well, much less women are dying in childbirth, and more women actually, when they give birth, they're doing it in a facility or with a nurse or somebody trained. More women have access to contraception, which is big. More women are getting prenatal care. So. And then HIV, malaria, and other infectious diseases. There's been an absolute, well, we'll talk specifically about HIV. It's come a long way. It's nowhere near cured or taken care of, but in 2003, basically nobody in sub-Saharan Africa was on treatment, and now there's 13 million people. So, and then here's environmental sustainability. Here they talk about the number of people who've gained access to clean water. 2 billion people have gained access to water. Ozone is no longer as severe problem as it was. On the other hand, carbon concentrations and temperature continue to rise. So I think the move to sustainable development is good. So I guess I had to ask I like to ask big questions like, what is development? I mean, so I looked at your website. And here it says IDS, International Development Study, is social, political, economic, cultural, and environmental change, not necessarily improvement, but change, taking place in low-income countries and regions. Didn't include health, I noticed that.
Well, that would be a social issue.
Okay,
Health and education would be social issues.
okay. Okay, so what's development? I had to look that one up too. And at least in the dictionary, it's to grow or cause to grow and to become more mature, advanced, or elaborate, which to me might be progress, I don't know. And usually development is actually measured. It can be measured, and how do they measure it? Well, traditionally they did it by GDP or income. But increasingly, when we talk about development now, it's got other things such as access to education, health is in there, equity, is income widely or unequally distributed. And in fact, there's something called the Human Development Index. Have you guys ever heard of that? Where they take into fact lots of these other factors, and they actually give a score, and there's a ranking, and usually the Northern European countries and Japan are in the top 10. US is usually about 20 or 30, and the places I've been working are in the bottom 10. So, but I actually like this definition here because I think it's relevant, which is development is the capacity of economic, political, and social systems to provide the circumstances for the well-being and for the well-being on a sustainable long-term basis. Because we talk about unsustainable development. In fact, do you guys think the world is developing sustainably or unsustainably right now? Why is that?
It's because the economy is so bad in some countries.
Okay, so do you mean the economy won't sustain progress or our income level? Mm-hmm. Can the earth sustain the development that's going on right now with us producing more and more goods?
Resources out.
Right.
And polluting so much that it's unsustainable.
So the new emphasis is on sustainability. I think that this is useful for health because I'm going to say, are these things that we're doing in these countries, will they be sustained after the effort is over too? So there's sustainability from that sense. So here we go. What is sustainable? Able to be maintained at a certain rate or level. Can it be maintained? And there's an ecological understanding given where the earth is right now, I think. And here's the UN's definition of sustainable development. Development that meets the needs of the present without compromising the ability of future generations to meet their own needs. I like that one. And again, we talk about needs. They say essential needs. Well, that's like food and water. And then every culture has certain limitations. They're doing the best they can given their technology, the way their country's organized, their economy. That can change. So sustainability, what is sustainable can change if we become, if our society changes, our technology changes. Okay. So this has been brewing since 2012, and they've come up with a whole new set of goals, which I think if you're taking development, it's useful to know what the Sustainable Development Goals are. And this is a shorthand version of them. Now there's 17 of them, and each of these ones has like 30 pages written on it and a bunch of targets, and I didn't want to bore you with them. But just so you can see that they're very comprehensive. No poverty, no hunger, good health and well-being, education, etc. So it's not that we're going to stop development. In fact, we're going to continue to develop it, and we're going to develop in a way that societies can continue in a sustainable fashion, is my understanding of the approach here. Questions?
Well, some of these, I mean, it's more complicated because sometimes building more industry can then, actually be less sustainable and increase consumption. So
Totally. Yeah, so how do you have economic development, sustainable economic development? I haven't read the whole thing. I just thought it's worthwhile knowing about this. So we're going to talk about health, since that's my area, and basically ensure healthy lives and promote well-being for all. And they have 10 pages of specific disease targets, and I decided not to give that to you, although I have it if you're interested. All of which, to get there, though, will require greater investment in health. So, all right, here's my question. The relationship between health and economic development. What comes first? What's the chicken, what's the egg here? Do you need health to develop? Or do you need to develop to get health?
Probably you'd have to develop some stuff before you get help, because, I don't know, in like more low-income countries, like you said previously, there's a lot of, like a very high death rate, and then as they, I don't know, I guess gained more technology and things like that, their death rate dropped.
Very good, yeah. Well, I just showed you all these slides of these poor countries having people dying early. So certainly they go together. But you could say the other too, that you have to be developed to have access to health care,
Right.
to have clean water. If you don't have money for a well, you're not going to have clean water, therefore you're going to be sick. So the reality is they're highly interrelated. Oopsie. So health can increase productivity. People aren't sick, they go to work. They have nutrition, that means children are born at a full body weight and have full brain development, and that means they're more productive. And we know that if you don't have food and clean water, education, access to health care, you'll be sick and you won't be productive. So they're highly related. And in fact, health interventions in this paper, which we'll talk about shortly, are estimated to contribute 24% to progress and development. So they're both. And getting out of that bottom, getting out of the poor health equals no development equals poor health is the vicious cycle that Africa has been trapped in forever up until about 50 years ago. So it takes a bit to get out of that, and then countries start to really zoom ahead. But actually, it's not necessarily income. It's certain key health interventions that really have been responsible for the bulk of the increase in life expectancy. And that's like vaccinations, that's like control of infectious diseases, pneumonia, diarrhea, it's childbirth, and taking care of newborns. There's about 7 key ones that if you have those things, you can have a big improvement in health. So and that's even controlling for income. So getting a health system to give these key things is critical to getting countries out of poverty, okay? And you need a health system to actually give the vaccinations, nurses to be there for deliveries. Okay, so this comes back to you save lives today or tomorrow. Anyway, okay, so now I'm going to talk about humanitarian aid versus development. And by humanitarian aid, I mean like disaster conflict relief. I'll have a little list of them. But it's like emergency food, emergency water. It's not building the system to maintain the food or to maintain the clean water. It's like there's been a tsunami, let's fly in zillions of emergency things that people need. So that's on one spectrum where you're not trying to improve the country, you're trying to save lives. And development down here, I'd say, is building the sustainable capacity for the country to do it themselves. Now those are, we argue about this. How do we spend this $50,000? Do we do it to save lives, or do we do it to help them build a system so they can keep saving lives? And this is just a quote: "Providing a person with a bed net or a water pump can often be an excellent, cost-effective way to improve her well-being, but if the improvement goes away when we stop providing the bed net or the pump, we would not normally describe that as development." That's an economist who wrote that. It's not a doctor. I'm a doctor. I'm trained to save lives. But I actually agree with the economist. So, and then there's a spectrum in between. And I'm going to talk about 3 particular programs where you can see that. But again, aid versus development assistance. Aid saves lives today, emergencies. It's often donations here. Let's give this medical equipment. Let's give stuff or goods, whatever they need. I remember during Hurricane Katrina, and all these poor countries were giving stuff to the U.S., and it was all piling up in the dock and going bad. So that's sort of, in some ways, the bad side of emergency assistance, is often the system to use the stuff is not given as well. And it's urgent, and it's usually led by the people who are not the ones in the emergency, because the people having the emergency aren't at that moment. They're dealing with the emergency. They're trying to survive. They're not planning. They're not budgeting, those kinds of things. Whereas development assistance, I say, save lives tomorrow, build the capacity of the country to provide the services themselves. And it's usually things like training, learning by doing, help setting up systems. But for it to be sustainable, the receiving country, the host country, needs to own it and learn to manage it, because the donor just has a temporary role. They're going away. So it means you have to work with the host country. You have to find out what they want, what the people there want. You have to figure out what's the next step for them to get there. And so it's much slower. You tend to not get lots of results right away, but in my experience, it's what will be sustained. Okay, so how do you build health? So how do you build a health system? And I'm just going to say they're kind of complicated. Given the mess we have in this country with our health system, you can see it's complicated. It's not just resources. It's how do you get everything in the right place? But it certainly involves, like, trained health workers, doctors, nurses, things like that. You need equipment, you need buildings, you need lab machines, you need drugs, supplies. But you don't just need the drug, you need the system of how do you get the drug to the patient, which is wherever the patients are, when the patients need it, at that moment, at that time. That's really one of the biggest challenges in developing countries. You need information. You need to know what patients go on where and what their medical history is. You need to have what we call systems of care, where nurses know how to treat certain things, or dietitians know that you treat this. You're not figuring it all out yourself. You're learning it from books and from systems and using protocols and medical records and charts and things like that. So there's systems of information. And then you got to pay for it. And if you don't pay for it, it doesn't work. And I promise you that developing countries usually have very little experience with payrolls and incentives and performance bonuses or insurance systems or all the different complex financing mechanisms there are to pay for healthcare. And then you really do need, ultimately, a healthcare system usually relies on the healthy to pay for the sick in most of the world, because people, newborn babies, people who are old and dying, people who are really sick, are generally not the people with the money to pay for the healthcare. So there's an element of a social solidarity system for an effective health system where there's some, I pay insurance now knowing some of it is going for people who can't pay for themselves. And I hope that when I'm no longer earning money or I'm on Medicare, that is part of the system. And in countries that just have pure private sector free market healthcare systems where everybody just pays for themselves, there's usually a whole lot of people going without any care. So it takes a sophisticated country to actually learn to develop this sharing kind of thing. And we've had problems with it here. Okay, so I'm going to talk about 3 different health activities if we have time. We got time, don't we? Yeah, lots of time. Okay. Questions? Did any of that make sense? I'm saying some potentially politically inflammatory statements.
Especially about the markets, because we're kind of in an era still where free markets are assumed to be the be-all and end-all. So if you don't believe in free markets, what does that mean?
Well, if you think of health more like education, which most of the rest of the world does, there's generally a commitment to public education because as a society, we're way better if everybody can read than if 20% of the population can't read. So we don't have that much problem paying for public education, but we sure do in this country for healthcare. But in the long run, it's actually cheaper to pay for a certain set of basic services for everyone than it is to make sure I'm only paying for myself, because those people end up going to the emergency room. We don't want to send them away if they're going to die, and that means we're paying for them one way or another. And it costs a lot more if you don't plan for it, which is kind of where we are. Sorry, I'm still sounding like a... Anyway, okay, I'm going to talk about 3 different major development activities. One is called Gavi, the Global Alliance for Vaccines, and it's a huge program where actually the rich countries contribute to vaccinating the poor countries, and it makes sense because otherwise there'd be polio all over the place and measles all over the world. So it's in our own self-interest to help pay for these programs. I'm going to talk more about the HIV/AIDS program because I know that best, and then I'm going to talk about something called universal health coverage, where I'm really going to talk about how do we pay for health care, because I think it's a major issue these days, and the rest of the world is ahead of us on this. Okay, childhood vaccines are pretty much the most cost-effective health measure to save lives and increase life expectancy. It's generally a pretty simple intervention, right? You get 1 shot and you're once and off usually. You might have a series of 3 shots, but it's a single thing that can save the lives of children. And there's pretty much universal agreement that with vaccination of everyone, say for polio, this was our first polio-free year, I think. I don't quite remember. Yeah, I think this year. Now there's been a resurgence since then. It might have been last year, but we eradicated smallpox through vaccines. We are almost on the cusp of eradicating polio. Now there's some 20-some conditions that are vaccine preventable, from measles to tetanus to pneumonia to various ones. But because there's such consensus on the importance of vaccines, basically there's an alliance where rich countries give money to buy vaccines to give them to low-income countries. They do this in a really good way. They use their buying power to get cheap vaccines. They basically have enough of the market share that they can lobby to really get the cost of vaccines reduced. They also require the recipient countries to pay something because they think the recipient countries should value what they're getting. And they also give something called performance incentives, meaning the higher your vaccination rates are, the less you have to pay. So it motivates countries to do a good job in getting 90% or higher of their kids vaccinated. And it's been in existence for over 10 years. They have increased the number of vaccines they're offering. Now, it's not pure what I'd call aid, because countries have to do their share. They actually get the vaccine, and then they have to turn around and get the vaccine to the kids. And that is not easy for a country that doesn't have transportation or running water or electricity, because vaccines have to be kept cold, and there's something called a cold chain. So they actually have to keep the vaccines on ice or refrigerate them and take them to the most rural parts of the country to get the kids there. So I've participated in lots of these vaccination campaigns, and they're complex. They have to get out the word. They have to track. Everybody has to have their immunization card. And that's an amazing development, so that you'll see mothers taking their kids to clinic, and the one piece of paper they have is that yellow vaccination card. That also includes the child's growth rate and major illnesses, medications, but that's their medical record, which every mother keeps track of. And they estimate, in terms of return on investment, that there's $18 gained for every $1 spent in terms of healthcare costs prevented. So that kids are not going to the hospital, they're not sick, there aren't wages lost taking the kid to the doctor. And if you take into the account the broader benefits of people living longer, because they're not dying of measles, the return on investment rises to $48 per every US dollar spent. So there's pretty much, everybody loves this program in the world, and countries keep doing it. So that's, I think, just really good success. There are some issues they got right now, but overall it's going to do well. And then my question is this aid or development, or what do you think? Anyone disagree?
Emergency aid versus kind of long-term development assistance.
It's a bit of both, I think. It's a bit of both. Because you're given the vaccine. But they also have the system. Yeah, yeah, it's both.
Do they have a plan to actually shift more and more of the management and so forth to the countries, or like shift it so that eventually they can buy their own vaccines and so forth?
I don't think they are, and I don't think they should yet, because, well, I think as countries, okay, so the vaccines are targeted to the lowest income countries. So if a country develops economically, then they lose some of the vaccines.
Okay, that makes sense.
So they've got that system in place. Okay, now I'm going to talk about AIDS. And I don't know if you all were alive back then, but there was this almost inexorable march of HIV across Africa from 1982 to 2005. And the red is the prevalence rate of infection, how much infection was there. And you can see it. And it got to the point that life expectancy was falling in Africa. The rest of the world, everybody's living longer, not in Africa. And then right around here, there really was a sort of global outcry that, there's treatment in developed countries and the epidemic has completely stopped. I won't say it's completely stopped, but it's no longer an epidemic. It's no longer, out of control. You get on lifelong treatment and you have practically a normal life. And so there were huge programs. The biggest one was by the US government to introduce HIV treatment in Africa. And this is the US foreign assistance budget. So if we're talking about development and we're talking about where your and my tax dollars are going, they're going to this HIV program. This is the single largest item in our whole foreign assistance budget. Health is the single largest item. It's larger than, say, peace and security or helping war-torn countries. And HIV is the majority of health funds. And quite honestly, the HIV component is so big that the other ones are getting cut and robbed. And they'll complain about it, and rightly so. So we're not investing in economic development or democracy as much because this HIV program is taking up the budget. For better or for worse, that's what's happening. But the impact of AIDS in Africa, just briefly, before this program started, I'd go into a hospital and 90% of the people there had AIDS. The number of orphans tripled, school enrollment was dropping, struggling families adopted tons of kids. There were tons of children living in the street. There were households that headed by a 12-year-old. Women were being forced into prostitution because they needed to feed their children. The workforce was actually declining. It had a devastating financial impact, and the life expectancy in Africa dropped nearly 20 years. It's huge when you see what was going on in the rest of the world. Okay, but since then, starting 2003, there's been an enormous scale-up of people getting treatment. And it basically has reversed the fall in life expectancy. And this is a huge effort, because I know. And what did they do to get ART is the medication that saves lives that you take if you have HIV. Everything from learning how to do complex treatment in hospitals with no staff and no water and no electricity, who to prioritize, so we developed new protocols, had community health workers initiating treatment, and you can do that if you have these other systems in place, like protocols and stuff. So it's a huge effort. But But it wasn't just medical care. We renovated health centers, labs, electricity, bought computers, bought medical equipment, educated whole communities. All these children have HIV. Look how healthy they look. Empowered women, because women are the largest group of people with HIV in Africa. Teenage girls are the fastest growing group of people with HIV in Africa. So it was everything from health policy, all sorts of things. It was real capacity building. But we're in a peculiar place right now where all the people who started ART are still alive, and there's still only about half the people who have HIV know they have it. And only about 40% of people who have HIV are actually still on treatment. So even though there's been a huge improvement, there's a long way to go. And what's happening right now is there's a huge surge of people who have HIV, most of whom are on treatment or hopefully going to get treatment. And taking care of those people is just sort of taking up all the resources in development, international development in the US. But if you were to stop that, all those people would die. And so they call that a treatment mortgage. Basically, the US started this, and we can't get out of it. We shouldn't get out of it. There's no way around it. There's just a way through it, which is to keep going and get all the rest of those patients on ART. And that's the plan, and they've gotten good enough at it that this number of people on treatment is still surging. And they're doing it for less and less money. For example, in the US, if somebody takes, somebody's HIV positive and on treatment, it costs about $25,000 a year for the medicines, the medical care. In Africa, it costs $125 a year. Just through a real streamlined approach, through negotiating drug prices, teaching all sorts of people on how to do this. So it's actually incredibly cost effective, but still, it's a big burden.
Could you talk a little bit about the people who started treatment but then stopped? Because I think, if I heard you right, it was maybe 60%.
No, you didn't hear me right.
Okay, so tell me how many people, if 50% of the people actually knew that they had
Right.
HIV/AIDS.
The ones who know that they have, once have been tested and put on ART, about 80% of them stay on ART. And that's comparable to the US.
Did you say only about 40% no?
Yeah.
So
They haven't been tested, they haven't been found.
huge.
So you know with HIV, yeah, you know with HIV,
So like, our goal is to like,
get them, yeah.
yeah, wow.
With HIV, you get infected through intercourse usually. And you're fine. You're not sick, you have no reason to go get tested. That's the last thing you want to hear about is if you have HIV. You don't get sick for 10 years. So that's the cohort that doesn't know they're infected. Now there's been massive education and there's been steady progress, but that's also the reality.
It's a big investment.
It's huge. But I'll tell you, we have made more friends in Africa.
Oh, yeah.
Is there also quite a bit of spending then on prevention?
Yes. Well, yeah, it's been interesting. When this whole program that is called PEPFAR, the President's Emergency Plan for AIDS Relief, started by George Bush, there were major, what we call earmarks. You had to spend a certain amount of money on counseling for abstinence. That pretty much has gone away because it didn't work. And now the philosophy is actually find all the patients with HIV and get them on treatment, because treatment is prevention. Because if you're on treatment, you're not infectious. So yes, we still talk about safer sex and condoms, and if you're not infected and your partner is infected, you should probably take prophylactic medicine to prevent you from getting infected. So there is prevention, but the bottom line, and that's been the reality in developed countries, is treatment. Okay, so again, there's this surge of ART patients. I'm going to skip this. So what the goal right now is what we call transition, where actually the number of new infections is less than the number of people on treatment, so that the total pool is shrinking. And if they get past this point and transition and everybody gets on treatment, then the epidemic will stop. So, but that's still a huge commitment.
How do countries in sub-Saharan Africa react to that? I'm sure that they can do prenatal testing or maybe among military recruits, but are there ways to get the general population in to test? Or have they...
Oh, there's huge campaigns. There's absolutely huge campaigns. It depends on where, let me go back to this. Okay, you'll notice that really the epidemic is way worse in Southern Africa than in Northern Africa. And the real reason for this is that there is a big migration of Africans to South Africa for jobs, men. So men migrate to South Africa to work in the mines or for other jobs. And they are far away from their families, they have sex, they spread HIV. So the prevalence in South Africa has more people with HIV than the rest of the world. It was as high as 25%, so 1 in 4 people had HIV in South Africa. I worked in Mozambique right here, so I was right next door, and in the southern part of the country, the prevalence was also 25% because we were fairly near the mines, and a lot of people, men in Mozambique, would go work in the mines. So yes, I would suspect everybody in South Africa has been tested several times, so they have massive campaigns. Up in this part of Africa, the prevalence rate is really maybe 2 to 3%. So there, it's harder to get people mobilized.
You said all of this have, like these, I mean, these are at least 10 years old. So you said that these have...
I haven't seen a more recent one. Yeah, it's decreased. Oh yeah, prevalence has dropped. Like in Mozambique where I worked, when I first started working there, it was 13 or 14% as a national average with a lot of local variation. It's down to 7 or 8%. So yes, it's made a huge improvement. Nonetheless, there still is a reservoir of people who don't know they're infected. Okay, sorry, where was I? Okay, so that's it. Any other questions on HIV? It still is a huge problem, but there's been enormous progress again. Okay, universal health coverage. What the heck is universal health coverage? It's complicated. It's probably, in my mind, actually, why don't you just pass these back? You can pass those back. It's what I would consider the heart, or the most important development thing to get to, which is how do you arrange a healthcare system so that everybody who needs healthcare can at least get basic services. And the definition is, don't look at that document yet, I'll get there. But universal health coverage means that all people can get the basic health promotion, health prevention, cure, rehab, and palliative health services they need of a minimum basic quality to be effective without going broke, without spending all their money. And over 100 countries in the world are making measurable progress to have, most of the countries that have some middle class and higher, so that people who are sick can access health care, including the US. We've come a long way. I'm saying the free market does not increase the efficiency and improve quality and health. And that is actually, I took a World Bank health financing course, and they gave a lot of examples on why the free market doesn't work. First of all, there's a lot of monopolies in healthcare. Not anyone can go be a doctor or put up their sign to deliver healthcare. You have to pass tests, you have to get accepted, you have to make a major investment. So usually healthcare providers are licensed, and so there's restrictions and controls on them. So it's not a free labor market. Again, the people who need healthcare are often not the ones who have the money to buy the healthcare. Babies need healthcare. Consumers are not good judges of efficient spending. So they don't have the information to know this doctor is better than that doctor, or this procedure is cost effective and that one is. I don't know about you, but when I'm sick, I don't ask questions about, you know, should I go to you or can I buy this over here? I'm sick now, I want this now. So consumers are not good purchasers of healthcare in general. And often the choices consumers make, they don't go after, you know, the best bang for the dollar. They go after save my life. So there's many reasons basically why just a market approach to healthcare doesn't work. We talked a bit about you need a social willingness to help take care of the vulnerable. And not all countries have that. But the first step is usually to find a basic healthcare package of services for all. Like you're going to pay for vaccinations, you're going to pay for deliveries, you're going to pay for prenatal care. It's not a carte blanche. You don't pay for everything. You need to be able to collect revenue through taxes or through insurance systems. So it takes a fair amount of social development to have this. But Mexico, Brazil, Costa Rica, Cambodia, Thailand, a lot of middle-income countries actually have made impressive progress and have better health, a healthier population than the United States does. So from my perspective, and then this article was when the Sustainable Development Goals were approved, 44 economists, led by Larry Summers, who is a big shot economist in this country, president of Harvard, used to be, I don't know, more Democratic than, but he's Secretary of the Treasury or something like that. Anyway, economists from 44 different countries said the most important way to make sure that these basic services that promote development are financed would be promoting universal health coverage, so really helping countries develop financing systems so that everybody can access a basic set of quality packages. And that's the opposite of aid, in my opinion. It's sort of how do you really build capacity of a health system to take care of its population in the most urgent ways. And this is a big activity right now in many countries around the world, is setting up a combination usually of health insurance, taxation, targeted services towards the most vulnerable. And we have a lot of that in place. We just have the most expensive healthcare system in the world. Anyway.
Very piecemeal. You know, I'm a little bit familiar with the Thai case. It seemed like periodically, maybe actually year by year, they are about to go under. And so the government is basically paying for it because such a large group of that population is considered to be old or very poor or young, and so they're getting it for free. And so then there's nobody paying into the system. And so, you know, it's kind of working, but the government is just basically paying for it the whole thing. Not really getting it from taxes or from insurance or.
Well, they're getting it from somewhere, probably through taxes.
Oh, okay, yeah, this is true, but they're not taxing any of the people that I live with out in the rural area. They don't even pay taxes.
Yeah. Well, if you have an informal economy where you're not paying any taxes, that's one of the challenges for developing countries to set up a system because they don't have a way to pay for the government, any government, their defense system, education system, or their healthcare system. So setting up a taxation system where people pay income tax is a prerequisite, and that's hard to do.
Do you think that our system of having all these competing insurance companies is hindering our attainment of the goal of universal health coverage?
I think it was progress. It's not the answer, but it was progress. I mean, because we were stalled for decades of not doing anything. So it has certainly increased access to 20 million people, I think, for healthcare. It's not, I don't think it's the most efficient system.
Would you like to see a single payer health system here?
I think,
Universal, kind of a socialized medicine approach?
well, I think a single payer is different than a single provider. And yeah, I think it's good to have a choice of providers and for consumers to have choice. I do think if you had a single payer does dramatically simplify the whole insurance billing system.
It would lower costs so much.
But I don't think we're ready for it.
No, probably not.
No. Okay, so I'm sorry, that's my rant.
Oh, no, you've got plenty of time. We go till 8:20.
But I'm done.
Okay.
Oh, so these are just my take-home. So there's been enormous progress. If you think the world is falling to pieces and there's no hope, there's been enormous progress, huge progress. And I think there's what we call, there's been transformation of the health of the world. And there are strengthening health systems, so it's come a long way. But what you do is actually, if any of you go into the business of development or public health, you know, I think we want to invest in something sustainable. So figuring out what will last and what will have greater impact there's a lot of stuff written on it, and it's important to sort of consider that and decide what you want to do, rather than just go say, I'm going to go help do something. I mean, it's all important, but I think there's some things that are more likely to be sustainable than others. And we need to save lives today and tomorrow. So you can't do one or the other. It's both and. So I'm sorry. That's it. I don't know. That was.
Questions from the audience? You covered such large ground, and I really liked your examples, but we can take more questions. It's a fascinating set of topics.
When we look back at the millennial SDGs, or their MDGs, there were 8 of them. I only got to number 7, when we started talking about ensure environment and sustainability.
Oh, the last one was strengthen global partnerships, or someone that was sort of kind of blah blah. So I mean, yes, it's good. It's a feel-good one. We need partnerships, yeah. So sorry I missed that one, but.
I thought I just did.
This doesn't necessarily pertain to the lecture itself, but are we gonna have access to these slides? There's a ton of information on them.
So what's going to happen is MCAT is recording each lecture. They will, I guess, air it on TV, but eventually, maybe with a 3 or 4 week delay, we will get it.
Okay.
And we will post a link to it on our IDS website.
Okay.
So, but in terms of a summary and critique, I don't care that you got every little piece of
Okay.
information,
Just
but you
like
just want a
eventually
summary that
we'll be
may
able to like see it all.
But yeah, if you wanted to rewatch it, I think
Okay.
that would be the best way to get it.
I'll send it to you, and so maybe you can
Yeah.
also send it out then if you want.
It might be a big file, so I
Right.
don't think so. I think that this is gonna be the way that we'll do it, is with posting those MCAT
Okay.
slides.
Cool.
Yeah. Thank you. Oh, look, it's healthcare. So this is in remote rural Thailand in Phayao, and this is a 2-year public health worker, so that's one way that it's sustainable in Thailand. Although I have to say he was a terrible health worker, because we went with him, and he was supposed to be going, as I said last week, twice a week, and he was only going like once a month, because the mouse and the lizard poop was like an inch deep. We had to like shovel it out before we could meet the people. We had to go through all the drugs because they've been chewed.
Oh.
And so, you know, like, by mice. Yeah, so this is like one case where, you know, Thailand's trying, but it's an ethnic minority village, so getting the least attention and the worst workers, but trying to, you know, help them out, but it's just not, in my view. And actually, in the view of the local practitioners, that's why we were visiting him, because he hadn't been going. So we're like there to visit him and kind of shame him into going.
It's really hard to work in these settings when you don't have basic services like water or electricity.
Yeah,
It's really
yeah.
hard.
And he didn't want to live there. A previous one had actually lived in the village with a family, but you'd have to live with a family because there wasn't rental housing. There may have been a little bit of electricity, but not much else, you know, to do, nothing to do in the town, very remote, so. More than an hour from the nearest doctor. But, yeah. But things have changed, because people my age, I'm 52, even people 10 years younger than me, remembered having to hike down to the county seat, which would take them all day to go see, you know, some sort of medical provider again. At the time, they wouldn't have had a doctor.
So did I mean, you both have gone like internationally to do these sorts of things. Do you both have to have like an extensive like immunization process before you can travel there, or
I got one of
while you're
everything,
there,
yeah.
or
I've had one of almost everything because I was in the Peace Corps. Thailand is not as bad as some places. It's mostly no longer malarial, so that's not so bad. But yeah, the county public health office here is really handy. And so they can give you all sorts of
Yeah.
vaccines.
Yeah,
Here she
specialized.
is. Yes, here they are. So, but they do all sorts of vaccines. They have a travel nurse that tells you exactly what to get for each place and so forth. So, knock on wood, you know, haven't got really sick.
Well, thank you all.
So thank you.